White blood cells normally protect healthy tissue, yet these same cells can be reprogrammed to attack the exact structures they were designed to defend. This failure occurs across a spectrum, from the localized mechanical wear of osteoarthritis to the systemic autoimmune strikes seen in rheumatoid arthritis and lupus, eventually reaching the unchecked replication of cancer. Clinical decisions, such as interpreting lab values or selecting an intravenous drug, depend on identifying which of these specific biological mechanisms has failed. Mastery in this field requires mapping the disease's cellular mechanism directly to the pharmacological intervention. This analysis will demonstrate the relationship between the cellular target and the clinical cost of treatment. Osteoarthritis represents a non-inflammatory mechanical failure. Over time, the articular cartilage within the joint degrades due to physical wear. Here, the image highlights the joint capsule. Healthy cartilage on the left provides a smooth buffer, while the osteoarthritis on the right shows thin cartilage and bone spurs. This mechanical damage causes asymmetrical pain that worsens with activity. In contrast, rheumatoid arthritis is an autoimmune disease, the immune system targeting the synovial membranes, resulting in chronic inflammation. This autoimmune mechanism creates symmetrical joint pain. Patients typically report morning stiffness lasting over 30 minutes, along with systemic symptoms like fever and fatigue. These red, swollen joints illustrate the physical markers of autoimmunity. While osteoarthritis forms bony Heberden's nodes at the fingertips, rheumatoid arthritis typically avoids the distal joints entirely, focusing its destruction on the larger knuckles and wrists. Systemic lupus erythematosus deposits immune complexes across the body. Beyond the characteristic butterfly rash, lupus can actively destroy the heart and kidneys. Diagnostics follow the mechanism. Osteoarthritis is confirmed through physical assessment. Rheumatoid arthritis requires testing for rheumatoid factor and anti-CCP. Lupus screening uses ANA, followed by anti-dsDNA for a definitive confirmation. One process reflects the slow mechanical failure of a joint, the other an immune system actively executing a strike on its own host. Medications are selected based on the scope of inflammation. Localized osteoarthritis is managed with analgesics like acetaminophen or NSAIDs, targeting pain directly at the site. Systemic flares in lupus or rheumatoid arthritis require corticosteroids, acting as broad immune suppressors to control acute inflammation. While analgesics manage symptoms, DMARDs alter the disease course by intervening directly in the inflammatory cascade. Methotrexate suppresses the overactive immune response, requiring continuous monitoring of liver function and bone marrow. Hydroxychloroquine introduces retinal damage risks, making eye exams mandatory. High-potency drugs intended to halt systemic destruction carry inherent toxicities. The clinical goal is managing the collateral damage to the liver, eyes, and bone marrow. The systemic map shifts from autoimmune failure to malignant growth. Cancer is a failure of cellular apoptosis, where damaged cells replicate without stopping. This rapid division is often triggered by environmental factors, like tobacco smoke or UV light, which damage cellular DNA. The TNM staging model tracks this progression. We measure tumor size, node involvement, and metastatic spread to determine the severity, from stage 0 to IV. The primary colon tumor in this image demonstrates the mechanism of metastasis. It sheds malignant cells into the vascular and lymphatic systems. These traveling cells use the body's own transport networks to establish secondary tumors in distant organs, such as the liver and lungs. A tumor becomes a systemic threat once it accesses these networks, shifting the treatment from localized surgical removal to systemic chemotherapy. Anti-neoplastic drugs are grouped by their method of disrupting cell division, including alkylating agents, folate acid analogs, and mitotic inhibitors. These drugs eliminate tumors by targeting fast-growing cells, but they cannot distinguish between malignant cells and healthy tissues with high turnover rates. This lack of specificity destroys white blood cells, red blood cells, and platelets. The patient becomes severely anemic and loses their ability to fight infection. Managing neutropenia requires protective isolation and strict hygiene protocols. Because drugs damage skin integrity, mild soaps and gentle care prevent secondary infections. There are also mechanical risks to the delivery of these drugs. Infiltration occurs when standard IV fluid leaks into surrounding tissue, causing cool, localized swelling. Extravasation occurs when a toxic vesicant drug leaks. This clinical emergency requires immediately stopping the infusion and administering a specific antidote to prevent tissue necrosis. Oncological management requires sustaining the patient through the systemic effects of the treatment while it eliminates the tumor. We classify oncologic emergencies by their anatomical or metabolic impact. Superior vena cava syndrome is a primary anatomical threat. In this condition, a tumor compresses the main vein draining the head and neck, causing JVD and facial swelling. High Fowler's positioning is the immediate priority to assist venous return and maintain the airway. Tumor lysis syndrome is a metabolic emergency caused by rapid cell death. Bursting cells release massive intracellular content. Potassium, phosphate, and uric acid spike, while calcium falls. This imbalance requires aggressive hydration for the kidneys and continuous monitoring to prevent fatal arrhythmias. Immediate threats to life in oncology often stem from sudden anatomical compression or the metabolic debris following rapid cell destruction. Clinical judgment relies on determining whether a condition is a localized mechanical failure, a systemic autoimmune strike, or a malignant proliferation. This system map links the 3 disease categories to their specific monitoring requirements, specifically identifying the risks to the kidneys, liver, and heart. ESR and CRP track general inflammation, ANA screens for lupus, and constant CBC monitoring manages the risks of chemotherapy. Clinical intuition develops by mapping the mechanism of failure to the specific medication. This logic allows for the prediction and prevention of collateral damage.